Welcome to the PIERS Association Podcast. We're interviewing Dr. Alysha Vartevan, who's the DO and is here with us at our event from RAYUS Radiology. And we would love to ask you a whole bunch of questions. I personally am fascinated by imaging, and I know it plays a huge role in PI. So what got you interested in radiology in the first place?
You know, it's funny. When I was a third-year medical student, just on a whim, I decided I wanted to be a radiologist. And most medical specialties have kind of a general personality. The emergency medicine doctors are kind of the thrill seekers. The orthopedic surgeons are the jocks that work out a lot. Radiologists are not known to have the most glowing personality, so I'll say that. But I was interested in the technology, and I remember going to a conference when I was a third-year med student, and I was amongst a lot of radiologists, and it almost deterred me because I was like, I don't think I fit in with this group. Like, I really enjoy people, and I like to talk, and but I loved the problem-solving aspect of it. It's a lot of true diagnosis in medicine because you're kind of faced with a picture is worth 1,000 words, right? But that's your only piece of kind of evidence to figure out what's happening. So you've got your MRI, for example, you've got a symptom, and you're trying to figure out what's happening kind of under the hood to help that doctor take care of the patient. So I really loved that aspect of it.
Have you seen some really interesting things on imaging?
I have, especially in training. I would say my last year of training was the most interesting. That's when I did my neuroradiology fellowship. And I did it at a very high volume level 1 institution, and just everything that you could think of that you could possibly see within the brain and spine we saw during that year, which it was amazing. Loved it.
So how does imaging play a significant role in personal injury?
I am biased since I am a radiologist, but I think it's one of the most important pieces of I always think of it as a puzzle, and we're one of the most important pieces of that puzzle in helping validate what's happening with the patient. Personal injury is so different than the rest of medicine because you have a snapshot in time to take care of a patient. They've suffered some type of trauma, and now we have to prove it, right? Unfortunately, a lot of people don't believe the patient, or they don't believe this wonderful doctor taking care of the patient. And so the MRI becomes a very important objective piece of that puzzle. So it shows what's happening to the bones, to the ligaments or the tendons. Look at the discs. It's a very important piece of the puzzle to kind of validate and justify what the patient is actually experiencing and explaining.
So what you can see with imaging, there might be a disconnect with what an injured person is going through. You know, they may look fine on the outside, but can you explain a little bit more about what you see on the inside?
Sure. We always say you treat the patient, not the picture, because every patient can experience pain at different levels. But the imaging will really show we'll talk about the spine, if a person has any type of trauma and they have neck pain, and maybe that pain is going down their arm, we call that radiculopathy. And so when we get the MRI, we're able to actually see if there's a disc that's pushing on any of those nerves. And you really can't see that on any of the other imaging. You wouldn't see it on X-ray. It would be hard to see it on a CAT scan. And even with a lot of our diagnostic evaluations and our physical exams, sometimes you're just not able to localize that nerve as well as you can picture it on the MRI. So the MRI is very, very helpful to really localize the problem that's causing the symptoms.
Can you talk a little bit more about when we say imaging, it's a big category, but you've got different diagnostic tools for different things.
You do, yeah. So there are different what we call imaging modalities in the world of diagnostic radiology. Since I'm a neuroradiologist, I focus on the brain and spine, so we deal a lot with the MRI. But there's a lot of different modalities. You can have ultrasound imaging. You can have nuclear imaging, which is what you have with things like PET scans. So if someone has cancer and they need a workup, they'll usually get a PET scan done. X-rays, which are one of the best screening tools in our imaging world. A lot of doctors will actually have X-rays in their offices at this point. CAT scan is probably the most important modality in the emergency department. It's almost like a souped up X-ray where you can see a lot more than you can see on the X-ray, but it's very quick. Every patient can have a CAT scan. If you're in a trauma and you go to the emergency department, a lot of times you're getting a CAT scan of your head, your neck, your chest, abdomen, pelvis. And then the MRI is probably the most detailed out of everything, but every modality has its role to play in taking care of a patient.
So if someone's never had an MRI, can you walk through that process a little bit so that they're not fearful?
Oh, yeah, I can, because I have had MRIs, but
Me too.
It took me a while, actually. I think I had my first MRI at RAYUS here in Utah.
They do a great job.
They do a great
really
job.
Do.
They do a great job. It is a little bit nerve-wracking because the MRI is different than, for example, a CAT scan. So a CAT scan, you know, if we're going to talk about desserts, think about a donut. A CAT scan, you're going in and out of that donut hole pretty quickly. An MRI, think of like a cannoli, and you're going to go into that cannoli, exactly. And you're going to be in there for 15 to possibly 30 minutes, depending on the MRI that you're getting done. Different body parts, you may even have cages essentially over your head. It's
to hold
very
still.
To hold still, to help improve the image quality. It can be very loud. So usually they'll give you earplugs. They may even give you headphones on top of that as well. And what I would tell every single patient is just to close your eyes. Don't look, because I'm not claustrophobic. I've never been claustrophobic. But when I was in that MRI and I kind of peeked, I was like, I do not like this at all. So if you close your eyes, then you don't realize what's happening and you just kind of relax. And a lot of patients actually will fall asleep at that point. But it can be a little bit nerve-wracking knowing that you're in that MRI. Just remember the MRI technologist. So that's the person that will actually put the person onto the MRI table. They'll be taking the images. They'll have a little ball the patient can squeeze if they get nervous. The MRI tech is there the entire time. Nobody is ever leaving the patient. They'll make sure that they're very comfortable. They'll do all the appropriate screening ahead of time to make sure it's safe to have the MRI done. And just remind yourself that MRIs are done all the time, every day, 24 hours a day. It's a really great modality. It's going to help you figure out what's happening, and just keep your eyes closed. That would be the best advice I can give patients.
And you can hear the tech's voice in your earbud.
You can.
So that's helpful.
And they usually have like a nice soothing voice, and like they try to keep you relaxed because they understand too. They understand what the patient's experiencing.
And if you'll just hold still
Exactly.
and deal with it, they won't have to start over.
Exactly. I know when I had my MRI, when I had my first one, the tech was like, Dr. Vartevan, we're going to repeat that one. I think you might have fell asleep and twitched a little. I was like, oh my gosh, I'm so sorry. I'm like, I was that patient. I'm so sorry.
Well, you said relax.
I know.
You did.
I did. Yeah.
That's so interesting. So what keeps you motivated in this field?
I love radiology. So I'm involved in teaching on many different, different aspects. So I do a lot of mentoring with radiology residents. I teach medical students how to read MRIs of the spine. I'm very involved with the American College of Radiology. I was the president of the Arizona Radiology Society. I'm involved in my subspecialty college with the American Society of Neuroradiology. I truly love what I do, so that really helps keep me motivated. And I have a particular interest in traumatic brain injury, and there's a lot of changes on that front. They're changing the diagnosis or how they categorize traumatic brain injury right now. And I truly feel that there's patients that have a mild traumatic brain injury that are not being diagnosed and not being treated. And so that kind of keeps me pretty vigilant as well, because I know there's a lot of patients out there that are really just not getting the attention and the treatment that they need. And I mean, we all became physicians to take care of people. And so that kind of that continues to keep me motivated as well.
So you use the term traumatic brain injury and mild traumatic brain injury. Is there a big difference between the two?
Yeah, so traumatic brain injury is kind of the entire diagnosis, and then it's categorized in mild, moderate, and severe. And this is what's being changed a little bit. It's based off of something called the Glasgow Coma Scale, and it's deciding if a patient can open their eyes, respond to verbal commands, and move. So if you go to the emergency department and you even have a bleed in your brain, you may still be classified as mild traumatic brain injury.
Really?
Exactly, which is, it doesn't make a lot of sense, because if you think about it, you're like, patient shouldn't be bleeding in the brain.
Bleeding.
Exactly, yeah. But if you're able to follow these few commands, you're classified as mild. And the problem is, both on the mild side and on the severe side, there's some limitations for patients, because patients that are diagnosed with mild are almost discarded. They're like, you're fine, but they may not be fine. And it may be very subtle problems that are ongoing, but they really affect their daily living. And on the other end of the spectrum, severe, a lot of patients are like, well, you'll never get better. And so those patients almost feel forgotten about, because they're considered a lost cause at that point. So there are new classifications that are taking into account imaging is a portion of the diagnosis. But it allows patients who have mild to feel validated in their symptoms, and then people with severe to feel more encouraged that it doesn't mean that this is the end of your usable life. And so it's a really interesting field.
So I've heard talk about a special series that RAYUS does.
Yes.
That has been very helpful with chiropractors in their practices.
Specifically with the brain?
Yes.
Yes. So what we're doing at RAYUS is we'll do a conventional, or what I call sometimes a structural MRI. Mm-hmm. And that's the MRI that most people will get for any symptom, a headache, patients that have multiple sclerosis that have to get scanned annually. That is more that conventional MRI. And why I say structural is the things that we'll see on that MRI are things that you would see if you took the brain out of the skull and saw it with your naked eye. So this is the gross changes, like gross pathological changes. They do something called a DTI, which is a type of sequence based off of the movement of water. So it's a diffusion sequence. And it gets into a little bit the thick of physics. So there's math modeling that is involved, but there's different microstructure measurements based on this movement of water. One that we use a lot is called the FA value, or fractional anisotropy, and it talks about the directionality of water. So it's from 0 to 1, 0 meaning there's no organized or uniform direction, 1 is a perfectly straight line. So different structures in our brain will have varying FA values, and that's actually been linked to traumatic brain injury. And so that is looking at the brain at the microscopic level. So say the brain is removed from the skull and we're putting it on a slide for pathology, and we're using a very high intense microscope, and we're looking at what's happening at the cellular level. So the DTI is an attempt to look at what's happening at the cellular level without having to actually look at the cellular level, because we don't want to remove anybody's brain.
We don't want to scare anybody.
We don't do that. We don't do that in imaging. We're
non-invasive.
No, exactly, non-invasive. Yeah. So that's the DTI that they're using.
And then you also have a whiplash series. Yes. That has been helpful. It's obviously for the neck, but it's
Correct.
Also been helpful to find possible concussion.
It helps with headache generators. So you're trying to understand where that headache's coming from. Is it a cervical generated headache, or is it a headache that's from the concussion? Because obviously both can cause the same type of symptoms. So with that, we'll do a very specific protocol called the alar ligament protocol, and we'll look at the ligaments that hold the head to the neck. And they're very strong ligaments, but you can think about all the motion that's happening at the actual connection of the head and the neck. And so sometimes those ligaments can get sprained. And so some of those specific protocols will actually help us visualize those ligaments better.
Oh, so you get an accurate diagnosis.
Exactly.
Those are kind of important.
They are important. They are important. Absolutely.
Well, you sound incredibly busy.
I am busy.
Do you also have a life?
I do. I have a wonderful husband. I've got 2 great kids. I try to have very strict work-life boundaries. So before I start to work, I'm just a mom. And then when I pick up my kids, I'm just a mom. And so I try to keep that very separate. I had entrepreneurial parents who, your life is your business. And I am determined to try to keep nice, healthy boundaries so they know that I'm just a mom. I'm there to help with homework and, cook the meals and do all of that. So I keep my cell phone away because if I have it close by, work never stops. So you get the text messages, the emails, like, hey,
up.
Can you look at this? Hey, all of those things. So I try to keep healthy boundaries that way.
And RAYUS had the foresight to contract with your company.
Correct, yes.
Do you want to share about your company?
Yeah, I would love to. So I actually came to Utah with Larry, I want to say 3 years ago, and he had an event educating chiropractors, and he was like, hey, will you come up? I was like, yeah, sure, I'll come up. And those chiropractors actually put me in touch with RAYUS. They're like, oh my goodness, there's this Dr. Vartevan, please, we would love to send to you. We want her reads. So my company is called Camelback Radiology, and we're a teleradiology group. I have my 10th rad joining in October. We're subspecialized, so we're either neuroradiologists, MSK radiologists, or body radiologists, so we can cover you from head to toe in any kind of trauma. And with RAYUS, we read a lot of their trauma patients, so that's the majority of what we read for RAYUS. But yeah, we've got a great group of rads, and everybody's so wonderful to work with, and very fortunate.
Sounds like a beautiful life. It really does. You're doing what you love and having a good time doing it. And then think of all the people you're helping.
I love to think of it that way.
Yeah.
We don't get the same face-to-face, interaction with patients that a lot of our clinicians get. So we don't really get thank you, doctor, for helping me. Or I joke with the anesthesiologist, like they're the most loved in the OB department because, they come in, they give you the epidural, your pain is gone as a laboring mother, and they get, the thanks and the kudos. We don't get that as much. But we do have a really good relationship with our clinicians. And so that's where we really get some of that validation and praises from our clinicians. Like, oh my gosh, thank you so much for reading this. I knew something was wrong with my patient, and now I have that and I can take care of them appropriately. So that helps a lot.
Do you have any advice for chiropractic physicians and imaging?
Especially with a trauma patient, image early. That really helps because, again, we were talking about earlier how personal injury is a little bit different than the rest of the medical field. And it's because we have to prove everything. Like in the rest of the medical field, if you walk in and you're like, hey, my neck hurts, nobody's questioning that your neck hurts. Nobody's questioning the chiropractic physician that they have these positive findings on their physical exam. But in the personal injury world, because it's more of that legal battle, we do have to prove what's happening. And the MRI validates so much. And so the earlier you can get it closer to the trauma, the more of that edema or inflammation that we can identify on the imaging, which really, really helps, again, kind of show like, yes, this person was injured. Here are the objective findings. We can point to it. And that's why they're experiencing this pain. And hopefully they'll get better. And a lot of times we'll have follow-up imaging after they've been in chiropractic treatment, and everything looks better, which is exactly what we want for these patients.
That's beautiful. Thank you so much for joining us today. I've learned a lot.
Thank you for having me. I appreciate it.
Absolutely. And thanks for your support of PIERS Association.
Absolutely.
Thanks for joining us on the PIERS Association Podcast.